Neurology Quiz number 100. Describe the various types of autoantibodies associated with peripheral nerve disease. There has been a rapid increase in the number of antibody tests that allow diagnosis and characterization of autoimmune neuropathies. Autoantibody testing should be considered after a detailed history and examination, as well as EMG and nerve conduction study are used to classify the neuropathy phenotype. Phenotypes include demyelinating, axonal, autonomic, etc., which help to narrow down the autoantibody profile. Autoantibodies used in peripheral nerve disease can be classified into those seen in association with the following types of neuropathy: demyelinating, axonal, sensory neuronopathies, motor neuronopathies, peripheral nerve hyperexcitability syndromes, as well as small fiber and autonomic neuropathy. Demyelinating neuropathies, GBS and its variants. GQ1B antibody positivity occurs in the Miller-Fisher syndrome, Bickerstaff encephalitis, GBS with ophthalmoplegia, and acute ophthalmoparesis without ataxia. These conditions are collectively labeled the anti-GQ1B antibody syndrome. The antibody is found in 80% of those with Miller-Fisher syndrome and 65% with Bickerstaff encephalitis. Other antibodies include the GT1A antibody in association with the pharyngeal cervical brachial variant of GBS, and the GT1B antibody in association with a small percentage of acute sensory ataxic neuropathy. The GQ1B antigen is highly expressed in cranial nerves 3, 4, and 6, as well as muscle spindles and reticular formation in the brainstem. The binding of the GQ1B antibody to GQ1B antigens induces Miller-Fisher syndrome and Bickerstaff encephalitis. CIDP. 10 to 20% of patients with CIDP have antibodies directed against nodal and paranodal proteins. These are directed against NF155, NF186, NF140, as well as contactin-1 and Casper1. For NF155, the IG4 subclass is most specific. These subtypes have been classified as nodopathies and paranodopathies. Patients with the NF155 antibodies are most common, and clinical features include weakness, that is distal more than proximal, tremor, sensory ataxia, cerebellar dysfunction, as well as pain, autonomic dysfunction, and papilledema. A minority of patients have CNS demyelination. Such patients have a relatively poor response to IVIG and steroids, but respond favorably to rituximab. Contactin-1 antibody-positive patients can have an acute or subacute sensory predominant presentation and pain, as well as associated membranous glomerulonephritis. Casper1 or Contactin-1 complex antibodies occur in a minority, and these patients may have severe weakness. NF140 and 186 positivity is much less common, and cases reported have had severe subacute demyelinating neuropathies and cranial nerve involvement. Associated conditions include focal segmental glomerulosclerosis and retroperitoneal fibrosis. Some patients have been found to be positive for all isoforms of neurofacin, including NF155, 186, and 140. Such patients are labeled pan-neurofacin antibody positive. These patients have been reported to have a fulminant disease course with severe weakness in all 4 limbs and prominent involvement of cranial nerves, as well as autonomic dysfunction, and severe respiratory insufficiency requiring mechanical ventilation may also be seen. This figure shows a simplified molecular organization at nodes, paranodes, and juxtaparanodes. The location of the NF155, Contactin-1, Casper1, and NF186 antigens is shown. Distal acquired demyelinating symmetric neuropathy, or DADS. About 70% of patients with the DADS phenotype have associated IgM gammopathy. 50% of the patients with IgM gammopathy are positive for myelin-associated glycoprotein, or MAG antibodies. Clinical features include distal paresthesias, tremor, and sensory ataxia. Weakness is usually mild and distal. Nerve conduction studies show evidence of demyelination in motor nerves with disproportionate prolongation of distal latencies. Course is often indolent, but treatment may be required for ataxia and weakness. Such patients often show poor response to IVIG and steroids, as well as plasma exchange, but may respond to rituximab. This figure shows the mechanism of demyelination caused by the anti-MAG antibody with loosening of the myelin layers in loops at the paranode and internode. Multifocal motor neuropathy, or MMN. This condition presents as asymmetric limb weakness and atrophy in the distribution of individual peripheral nerves. In 90% of the cases, it involves the distal upper extremities first. EMG and nerve conduction study reveals conduction blocks outside the usual compression sites with normal sensory conduction. Anti-GM1 antibodies are reported in 40 to 80% of cases, but are not required for diagnosis. The antibody test may be helpful in distinguishing the condition from motor neuron disease. GM1 IgM has much higher specificity for MMN than GM1 IgG. MMN does not respond to steroids but responds well to IVIG. Axonal polyneuropathy, number 1 GBS variant. GD1A antibody positivity has been reported in up to 60% of patients with AMAN variant of GBS. This is a severe type of axonal GBS, with patients having a more severe course and often requiring mechanical ventilation. GM1 antibody positivity has also been reported in AMAN but is less specific. Subacute and chronic axonal polyneuropathy. Several neural-specific autoantibodies have been reported in association with subacute and chronic axonal polyradiculoneuropathy and neuropathy. These include the ANA1 or anti-HU, the CRIMP5, the anti-amphiphysin antibody, the PCA2 antibody, the AP3B2 antibody. Most of these antibodies, such as ANA1, CRIMP5, amphiphysin, and PCA2, are high-risk cancer autoantibodies and have cancer association in more than 70% of the cases. Clinically, the CRIMP5 and amphiphysin patients have asymmetric involvement and severe neuropathic pain. Coexisting myelopathy has been reported in some patients with ANA1, amphiphysin, CRIMP5, and AP3B2 antibodies. Sensory neuronopathy. Sensory neuronopathies are characterized by selective dorsal root ganglion destruction. Clinical features include numbness, burning pain, sensory ataxia, pseudoathetosis, and areflexia. Nerve conduction studies show absent or reduced sensory nerve action potentials with preserved motor responses. Paraneoplastic sensory neuronopathy is associated with autoantibodies. These include ANA1, PCA2, CRIMP5, and amphiphysin. Recent reports have shown that sensory neuronopathy is associated with fibroblast growth factor receptor 3 or FGFR3 antibodies. Some patients with Sjogren's syndrome and sensory neuronopathy may be AGO1 antibody positive. Motor neuronopathy. Anti-IGLON5 antibody disease can be associated with the motor neuronopathy and bulbar syndrome, causing dysphagia, dysarthria, sialorrhea, stridor, and respiratory insufficiency. Paraneoplastic motor neuronopathy with thromboencephalitis can occur in association with ANA2 and MA2 antibodies. Peripheral nerve hyperexcitability syndromes. These conditions are characterized by muscle cramps and stiffness, fasciculations, myokymia, as well as dysautonomia and neuropathic pain. Isaac's syndrome is a peripheral nerve hyperexcitability syndrome associated with LGI1 and Caspr2 antibodies, most commonly the latter. Morvan syndrome is similar, but in addition, there is associated encephalopathy with hallucinations, memory loss, and confusion. It is also associated with LGI1 and Caspr2 antibodies. These conditions may be associated with an underlying thymoma, which is more common with Caspr2 antibodies. Small fiber neuropathy and autonomic neuropathy. Autoimmune autonomic ganglionopathy, which presents with symptoms such as anhidrosis or orthostatic hypotension, is associated with ganglionic nicotinic acetylcholine receptor antibodies. Titers more than 0.40 have high specificity, whereas titers less than 0.20 can be nonspecific. Autonomic dysfunction, particularly chronic GI dysmotility, is associated with paraneoplastic antibodies, including ANA1 and CRIMP5. Antibodies to FGFR3 have been reported in case of small fiber neuropathy. Caspr2 or LGI1 antibodies have also been reported in association with small fiber neuropathy, which is responsive to immunotherapy. This table shows the different neuropathy phenotypes and the associated autoantibodies.